right? Any kid can fall down during playing. So it is 100% that these kids can have injury. So what is the nature of injury? So in the animations I have made, you can see there are two kids, this one, here, this one, who are actually falling down, but then getting up and then, moving forward with the game. So they haven't cried, there is no bleed. So there is obviously no sprain or fracture because they're continuing to play. So you understand that there are no symptoms or signs of injury. But because you're seeing them fall down, you know that injury has happened. So that is what is peri-op myocardial injury. Next, are there any precipitating factors? Yes, they can be child related because impulsive kids who are naughty, they don't listen to you, who are they take risks, they have higher chances. And kids who have already fallen down, got up, had fractures before, they have more chances of injury, right? So there are the child related factors. They are the game related factors, like if somebody is just walking slowly, the chances that they fall down are less, having injury is less. If somebody is doing somersault like this in the thing, that is very high chances that they can have injuries. Next, environment related factors, like because the kids here are playing in a lawn, there are less chances that even if they fall down, they don't hurt themselves. But if they're doing it on a road, on a rough surface, on a rocky surface, there are very high chances that they will have injuries. This is exactly what happens in peri-op, when you're talking about a patient. So what are the precipitating factors for the patient? There can be patient related, it can be surgery related, it can be anesthesia related. Okay, next, how do you diagnose it? As I told, because there was no bleeding, there was no sprain, there was no fracture, the patient did not cry, there can be only certain markers which can tell you that the injury has happened. Will there be any long-term effects? Yes. Yes or no? Because we know some of our injuries are very kind. They do not leave any scars on us. We just get on very well. But some of the injuries are very bad. Once we have them, they just remain with us. When you do the same activity, it can come back in the same way or in a severe form. Or that part, when you hit again, you have a higher propensity to have a fracture. So the long-term effects vary with each injury. That is what we are going to deal. So let us convert all this into a perioperative setting. Before we go into the topic, I would like to, brush something in our physiology that we have read many years before. The structure of a cardiac myocyte, we know it is a striated muscle which has myofibrils. In them are the myofilaments which form sarcomeres. These sarcomeres, they have the thick chains and the thin filaments, the myosin and the actin. Myosin is almost a 470,000 Dalton molecular weight molecule which has two heads, one to bind to the actin molecule to produce the action required. This is the troponin which has the actin. It is a 7-unit, like a spirally bound structure bound around tropomyosin. And then comes our heroes of today's session, the troponins. So troponin I, troponin C, and troponin T. Troponin C binds with calcium. Till the troponin C binds with calcium, troponin I is the one which is hiding the myosin from the actin so that it does not undergo any contraction. And troponin T is the one which is binding to the tropomyosin. So because as we go, we are only going to talk about troponin as a marker of perioperative cardiac injury. That is the reason we need to know what the structure looks like. So this is how it is. This is a light chain. This is the thicker, thick filament, myosin and actin. Once the calcium comes bind to the troponin C, the troponin I goes little away, the myosin head is disconnected from the actin, and so the myosin head is now free to bind with the actin filament and cause the movement. That is how the contraction occurs in the heart. So with this background, let us start with what is the definition of a myocardial injury. So there are multiple definitions. Just for the theoretical sake, let us see 3 or 4 very important ones. The Min Society Vision Group in 2017 have given definition is Myocardial injury is just to result from ischemia, obviously, right? And that has to be within 3 days of the surgery, with the high sensitivity troponin T more than 20 nanograms per deciliter. So this particular group has given a certain, the concentration of troponin that is very important to diagnose a perioperative myocardial injury. But they said you don't need to demonstrate myocardial ischemia. How can you demonstrate myocardial ischemia? It can be either by a symptom or a sign. Either patient should complain of a chest pain, ECG should show a change, echo should show a regional wash motion abnormality, and if any of these is positive, angiography should show a block. But you don't need to demonstrate any of this because it is just an injury, it is not ischemia or infarction. So, and the most important thing is, because we are talking about ischemia, any non-ischemic causes of myocardial injury should be ruled out, because if the patient is in AF, patient has a pulmonary embolism, or patient has, as I said, tachycardia because of any other reason, it is very high chance that his troponins may be elevated. In that case, they say you do not call it as a myocardial injury. So AHA in 2021, what they said is they did not give any specific number for the troponins. They said it should be more than 99 percentile. So the acute change, they said, was within 30 days, but most importantly within 72 hours after the surgery, as commonly said, because of the ischemic changes that happen in the heart, and you have to rule out the non-ischemic changes. As I said, the non-ischemic and the signs of ischemia should not be present in these patients. The fourth universal definition of myocardial infarction, they define myocardial injury as increased cardiac troponin more than 99 percentile, considered acute if, then you might ask me, if the patient has elevated troponins before surgery, then how do I know it? So in high-risk patients, if you have done troponins before the surgery, change of 20% of the value will tell you if it is acute and because of the perioperative period. And but in these cases, they have not given any timeline for the increase. The basal PMI, they have defined it as an absolute increase in high sensitivity troponin more than 14 above the baseline within 7 days after the surgery, and they have not said you don't need to differentiate ischemia and non-ischemia. Just any time if the troponins are high within 7 days after the surgery, consider it as perioperative myocardial ischemia. And the same thing, even the step compact, they have the similar definition that goes in defining it. So what is the incidence? The incidence is around 8% in the patients who are more than 45 years undergoing non-cardiac surgeries. And a recent systemic review and meta-analysis done by MINS, for them the incidence was around 17.9% in around 530,000 surgeries that were done. But as an average, you can take it between 8 to 10%. So, and the incidence also changes with what troponin are you measuring. If you are measuring a high sensitivity troponin, then obviously your incidence will be high. And if you are not measuring the high sensitivity troponin, the incidence will be low. And they said if you're measuring a troponin I, the incidence was 20%. With troponin T, it was 17.4%. So what are the risk factors? These are all the common risk factors we have for every surgeries. Older patients, male who are hypertensive with a history of coronary artery disease, prior myocardial infarction, heart failure, patients with kidney problems, emergency surgeries, they are all high risk. And usually they said general surgeries carried a higher risk than orthopedic surgeries, maybe because they were mostly done under blocks or regional anesthesia. So then let us little understand about the release of cardiac troponins. As we said, in the sarcomere structure, you have many troponins that are attached to the light chains which cause the contraction. But what we have to remember is there are a lot of free-form troponins that are present in the cytoplasm that are responsible for the initial release of the troponins after an injury. So let us just look into what happens when there is a little myocardial injury. If this is a structure of cardiac cell, what happens whenever there is a myocardial injury, initially there might be an increased proteolysis that can occur inside the cell. There can be formation of the blebbing, that is the vacuoles that form. These non-bound troponins can be carried through these membranes because of the increased permeability, and they can enter into the bloodstream and can cause increased troponin values. Or there can be a classical secretory pathway in which the troponins that are attached to the endoplasmic reticulum are transported to the Golgi apparatus, and from there they are released into the bloodstream. So these things happen in the initial phases of injury when the cell is still non-necrotic. But once the cell becomes necrotic, what happens is the troponins that are attached to the sarcomeres, they get detached from them, and these are the ones which are entering into your bloodstream. So initial phase of injury is just the free troponins that enter the bloodstream, and the later phase when the necrosis of the cell starts, it is always the bound troponins that are released into the bloodstream. But whatever it is, even if it is a non-necrotic pathway in which the smaller troponins are released, or the necrotic pathway in which large covalent complexes are released, our blood investigation cannot differentiate whether it is the shorter one or the complex one. It just gives you if it detects the troponins in the bloodstream. So any one of it will give you as a myocardial injury. So how do you differentiate it from the myocardial infarction? So in myocardial infarction, simple, because every one of us knows it, it is myocardial injury which goes beyond injury, because all myocardial infarctions have an injury, but all myocardial injuries don't lead to infarction. In the same way, like all injuries, all fractures would have had a history of injury, but all injuries don't lead to fracture. So along with it, they will have symptoms of myocardial ischemia. They'll show ECG changes. They may have pathological Q waves. They might show regional wall motion abnormalities during the echo, or if further investigated, they can have a thrombus in the angiography or the investigations done. So as I already said, all myocardial injuries did not lead to myocardial infarction, but all myocardial infarctions will have a history of myocardial injury. So then what are the types of myocardial ischemias? As we all know, myocardial infarction has majorly two processes, that is type 1 or type 2 myocardial infarctions. Type 1 is because of the disruption of the atheroma, which can block the vessels and cause ischemia. Type 2 is a demand-supply mismatch. It can be either because of a fixed stenosis that is present at that particular place, which is not able to increase the blood flow that is required because of the increased demand, or the increased demand supply mismatch, that is if you have a severe tachycardia where you're not able to pump enough blood during that point. So for us, during the perioperative period, studies have shown that normally what we see in our cardiology wards is type 1 MI mostly, but in the perioperative period it is usually the type 2 MI where there is a mismatch between the supply and the demand. So it can be because of hypotension, hypoxia, tachycardia, anemia, many factors which can precipitate it. So for us, during the perioperative period, what is more important is the type 2 injury. Then one question might be asked. Yeah, you're saying, anemia can precipitate injury, tachycardia can precipitate, hypoxia can precipitate, then what is happening? Okay, this is just one slide which is showing that usually most of the perioperative MIs are because of the type 2 MI. Okay, then let's discuss what we were discussing previously, the type 2 MI. As I was saying, the most common question that arises is what is happening to the auto-regulation that normally happens in everybody, which is because normally when we have tachycardia, everybody is not having myocardial ischemia. Then what is happening to that auto-regulation during the perioperative period? It is getting disrupted because of multiple factors that are happening during the perioperative period. It can be because of the systemic inflammation where there is an increase in the neutrophil lymphocyte ratio, the surgical stress itself, the hypermetabolism, the pro-inflammation via the sympathetic system, and these all causes a disruption in the cardioprotective mechanism, which cause a hemodynamic strain because of an increased preload and increased afterload also. And also there is always a segment of autonomic dysfunction that happens in the heart, which all of them together will lead to a cardiomyocyte damage. So outcomes, maybe I'll finish in 2 minutes. The outcomes, as we know, because obviously in a patient with myocardial injury will have a poorer outcome than the patient without a myocardial injury. So in-hospital mortality was 8% compared to 0.4% without an injury. 30-day mortality 8.5% in comparison to 1.2%. 1-year mortality was 20.6% in comparison to 5.1%. The long-term follow-up is usually not there in many of the studies, but data pulled from some of the studies showed that even the long-term mortality was high in patients who had a myocardial injury. So the basal PMI study also showed the same thing, that patients with perioperative myocardial injury had a higher mortality than the patients without a myocardial injury. And all the other things like acute heart failure, tachyarrhythmias, extra cardiac cases, type 1 MI, type 2 MI, they also increase the events in the patients who had myocardial injury. How do you prevent it? Simple, because we have to just maintain an environment that is ideal during the surgeries. Avoid hypotension, avoid tachycardia, avoid anemia, avoid hypoxia when and how much ever it is possible. So these are the things. Some of the studies have been done asking if continuation of aspirin will help, if beta blockers continuation will help, if statins will help. But till now, because it is a very new topic that is still under study, there is no consensus that has come up which will say that any of these drugs continuation might help or harm the patient. So I cannot tell you that these particular agents have to be continued in the preoperative period to have better outcomes. How do you manage it? As I said, this is a upcoming topic. There are very few studies who have concentrated on the management. There is one study called MANAGE, which is management of myocardial injury after non-cardiac surgery in 1,700 patients. What they have done is they have used dabigatran because it's an oral anticoagulant. They have given a dose of 110 milligrams BD for 35 days in patients in whom myocardial injury was diagnosed. What they found out was these patients were followed up for 2 years, and the major cardiac events, complications, were much lower in this group. What are the major cardiac vascular complications? Vascular mortality, MI, non-hemorrhagic stroke, peripheral artery thrombosis, amputation, or venous thromboembolism. Then you can ask me, were the side effects of bleeding increased in this group? As much as they observed, they did not. But what was the flaw in this structure, in this study is, in the selection bias itself, in the patients who were assumed to have an increased bleeding, they were eliminated from the study. So we cannot generalize these findings to the general population. So that is the problem with this study. So that is the reason I cannot tell this is the one you can follow also, but there are many studies that are coming up. So what are the current guidelines? The European Society of Anesthesiology Intensive Care, they say you have to do cardiac troponins before and after surgery for high risk. Why guidelines? Because after this talk you can ask me, we don't do regularly troponins for every non-cardiac surgery. But for high risk, you might consider doing it. The Canadian Cardiovascular Society, they say that in high-risk patients with raised pro-BNPs, it is important to measure troponins for 3 days post-surgery. And the AHA guideline says post-operative measurements can help the patient in the first 2 to 3 days after surgery. So what do we conclude regarding this topic is, obviously, like the universal precautions, preoperative optimization of the cases is very important. Identify the high-risk patients, follow a balanced anesthesia and analgesia. You should have a high degree of suspicion if you want to, suspect a patient with myocardial injury. And investigate only when required, because maybe our resources will not allow us to do troponins for all the non-cardiac cases serially. Studies are yet to come, so maybe in the future meets when we meet, maybe we'll have better studies which will give us better guidelines on this topic. Thank you so much.
Thank you, ma'am. Ma'am, we request you to stay back on the stage.